Hi, everybody. Welcome. So glad you're joining us tonight. We're here to answer any questions that you have about fertility, infertility, and the journey. But I thought I'd just begin by going through some of my most commonly asked questions and just sort of a brief overview. But again, feel free to use that chat at any time if things pop up that you are interested in. So what is the definition of infertility? Infertility is 1 year of unprotected intercourse without conception. And a lot of my patients ask, well, we're trying, but I'm not tracking my ovulation, or I didn't start tracking my ovulation until month 3. You can still count 1 year as 1 year, even if you weren't tracking your ovulation initially, but having unprotected intercourse through that year. When should a couple seek evaluation? Well, if the female patient is under age 35, we would recommend trying for a year and then seeking an evaluation. If the patient is greater than or equal to 35, then we would recommend they seek an evaluation at 6 months. However, there are sometimes concerns that patients should seek help sooner, that they don't actually need to wait the entire 6 months or a year. And those include irregular or no periods. This is pretty common. If you are not getting a period or your period is very irregular, it's going to be harder to get pregnant. And you may want to come and see us sooner because it's frustrating. You might not get a period or only get 2 periods over a 6-month time frame. And that's really frustrating. So certainly these are indications to come see us sooner. Painful periods, miscarriages, or a suspected male factor are other indications to come sooner. The other thing is that you can come straight to a fertility specialist or a reproductive endocrinologist and infertility specialist, or you can go to your OBGYN or your primary care provider. All of these are options. If you require a referral for your insurance benefits, then of course you might have to go to your OBGYN or primary care provider first. However, if not, you're always welcome to come straight to the reproductive endocrinologist with any concerns that you're having. Unfortunately, infertility is pretty common. It affects about 9 to 10% of married women, and 10% of women seeking gynecological care do so for infertility. It seems that in the most recent studies, that about 6.7 million infertile couples exist in the United States. I think this is really interesting. What's the likelihood that any couple without issues is going to get pregnant in the first month of trying? And you know what the answer is? 25%. And I think this is important information because a lot of my patients say to me, well, all my friends got pregnant the first time they tried, the first month they tried. And I usually tell them, well, those are usually the people that are talking about it, because there's certainly other people who didn't get pregnant on month 1 and they actually got pregnant on month 2, 3, or 4, because it's only about a 25% chance each month. And this should also be encouraging in the fact that if you don't get pregnant on the first month, it does not mean that there's anything wrong, and to continue trying. By about 6 months, we'll see that about 60% of couples will conceive. And by about 12 months, we'll see that 85% of couples get pregnant. So let's talk about a normal menstrual cycle. In a normal menstrual cycle, we have factors from the brain, the ovary, and the uterus that are all critical in achieving a pregnancy. In a normal menstrual cycle, it begins in the brain. The brain releases a hormone that tells our ovary to grow an egg. As that egg grows, it secretes estrogen, which is a hormone that tells our uterus to start preparing itself for a potential pregnancy. As that egg reaches maturity, what happens is a second hormone gets released from the brain. And that hormone tells the egg to release itself or ovulate. So that causes ovulation. And the egg then gets released into the fallopian tube. Now, once the egg gets released into the fallopian tube, so again, it grew here in the ovary due to hormones from the brain, a second hormone caused it to be released into the fallopian tube. When a couple has intercourse, sperm gets deposited in the vagina, and it swims up through the cervix, through the uterus, and it actually finds the egg in the fallopian tube, and that's where fertilization occurs. After fertilization occurs, it's called an embryo. When the egg and sperm combine, it's called an embryo. And the embryo then is brought into the uterus, and it moves into the uterus by thin hair-like structures within the fallopian tube called cilia to bring it into the uterus, where implantation occurs. So you can kind of see how complex this process is, and how if any one part is not working properly, we can have infertility. This chart here just shows the ovary on the top, hormones in the middle, and the uterus on the bottom. And it just shows how important each part is to having a successful pregnancy. So how can we optimize natural fertility? This is probably one of the most common questions that I get in clinical practice. So the first thing is understanding the normal fertile period. When are we the most fertile? Well, we're the most fertile 2 days before we ovulate and on the day of ovulation. Those are our 3 peak days of fertility, okay? However, we can still be fertile up to 5 days before ovulation, and then of course on the day of ovulation. So yes, tracking ovulation can be important in helping a couple to get pregnant, but it doesn't have to be so precise. Having intercourse the day before, 2 days before, the day of, or even, like I said, up to 5 days before, people still can get pregnant. So there's lots of different ways that we can track ovulation. In the office, we often do it with blood work. However, at home, people can do it with an ovulation predictor kit. These are often urine kits that are detecting that LH surge. That's that second hormone that's released that causes the egg to ovulate. There's also temperature charting, where women take their temperature in a resting phase every morning before doing anything, and looking for changes in temperature that are associated with ovulation. And then tracking a woman's cervical mucus is also a clinical indication that estrogen is present, and that ovulation is about to occur. Coital frequency. In English, that's having sex. How many times should we be having sex? And the answer is that usually you're going to have ideal success when people are having intercourse every 1 to 2 days around the time of their fertile period. It doesn't need to be every day. It doesn't need to be 5 times a day on the day of ovulation, but usually every 1 to 2 days around the time of ovulation. It's also important to avoid spermicidal lubricants. So a lot of times over-the-counter lubricants can actually contain elements that are toxic to the sperm. So there is one company that creates a non-toxic spermicidal lubricant called Greenside. It doesn't improve the chances of getting pregnant, but if a couple wants to use a lubricant, it's better to, obviously, when you're trying to conceive, not use something that's going to be toxic to the sperm. Environmental and lifestyle factors are really important, and Dr. Weiss may hit on this as well, but diet and weight have a big impact on fertility. Patients who are severely underweight or overweight can both have issues with both ovulating as well as getting pregnant. In addition, these issues can cause complications during a pregnancy and make it very difficult for the patients to maintain a pregnancy and increase the risk for complications. So we try really hard to get our patients into an ideal body weight while we're doing the workup and before they're about to conceive. Avoiding alcohol, drugs, and limiting caffeine. Caffeine does not need to be avoided completely, and that's kind of a common misnomer, but you can have 1 to 2 cups of coffee per day, and that should be safe on a pregnancy and your fertility. So you don't need to cut cold turkey. And then environmental factors, pollution, secondhand smoke, BPA, lots of different factors in the environment can certainly impact our fertility as well. Okay, so if a couple is having trouble conceiving, the first thing they may want to do is have a consultation with a physician. We start all our consultations now actually with a Zoom session. We do it on a different platform called Microsoft Teams, but we actually just meet with a couple and we go through their history, and we want to get to know them, and we want to know their medical history, their social history, their family history, and anything that we think could be contributing to them having difficulty getting pregnant. After that, we bring them into the office for a physical exam and further evaluation. And basically what we're looking for in our evaluation is, are there eggs? Is there sperm? And can the sperm and eggs get together? That's really, in a nutshell, what we're looking at. We do some additional testing as well, just to help to ensure the healthiest pregnancy that we can achieve. And that's with genetic testing and infectious disease testing. But the nitty-gritty of the fertility workup is eggs, sperm, and can they get together? So there's a variety of different causes of infertility. It could be a male factor, it could be a female factor, it could be both, it could be unexplained. Female factors include, like we discussed, maybe it's ovulatory dysfunction. Maybe you're not releasing the egg. Maybe the eggs are poor quality or low in number. Maybe they're in excess and just not being ovulated properly. Or maybe there's the presence of tubal and pelvic pathology that could be contributing. I know this is a depressing slide, but I think it's really important because I think the media does somewhat of a poor job in explaining this. But unfortunately, our biological clock as women is always ticking. And so we're born with the most number of eggs that we're ever going to have. So when our moms are pregnant with us and we are in their uteruses, that's when we have the most number of eggs. And by the time we're born, we've lost a considerable amount of eggs, going down from 6 to 7 million to 1 to 2 million. I mean, that's a pretty big drop just while you're in your mother's uterus. By the time a woman goes through puberty, she has about 300,000 eggs left. And then, of course, we're going to ovulate eggs during each ovulatory cycle. And some of the eggs will also be lost to something called atresia, which is cell death. By age 40, we seem to have, and again, this is all average, but approximately 25,000 eggs left. And at menopause, less than 1,000. So even at menopause, there might be some eggs left in there, but again, they're no longer functioning. And so as the follicles or eggs deplete, the quality of those eggs is also depleting. This slide could be shown later on in the talk, but I think it's important to see here. These are just average pregnancy rates by fertility clinics across the United States. These are not the Valley Hospital fertility rates, but I think it's nice for you to just see average across the country that fertility rates decline considerably as a woman ages. And I think that this is very upsetting because many of us might be choosing to wait to have children later, or for life circumstances, we're having children later. But unfortunately, it's important for us to realize that it's harder to get pregnant as we age. And we can see here that the pregnancy rates do go down considerably. And this is with fertility treatment. This is with IVF, the strongest fertility treatment. But even then, we cannot combat the effects of age. And I'm going to bring up another topic that I'm going to talk about a little bit later on, is something called egg donation. And that's when we use young eggs. So an egg donor, a younger person, is now going to donate their eggs for an older woman to carry. And you can see on that second line up here that maintains a pretty high pregnancy rate. So you can see here that the age of the uterus can be older. So let's look at our 44, 45-year-old age group, uterus. Okay, so they're carrying the pregnancy. Their pregnancy rate with their eggs is pretty low. But when using a donor egg, it's pretty high. And that really tells us that the impact of age is really primarily on the eggs. Of course, it can affect the uterus and lots of things can develop as well, but it has a much bigger impact on the eggs. I just put this slide up showing normal sperm parameters. None of us need to memorize this, but what I think is so interesting is that we talked about in one of the other slides how 1 egg ovulates per month. Occasionally, there might be 2 or 3 that ovulate in nature, but that's pretty uncommon for more than 1 mature egg to ovulate without fertility treatment. It happens occasionally, right? There's spontaneous twins out there, but it's not all that common. However, a normal sperm specimen has 2 to 5 milliliters in it, and there are 20 million sperm at minimum per milliliter. And so that just goes to show you we need a lot more sperm. Only 1 sperm is going to fertilize that egg, but we need a lot more sperm around to give us a healthy specimen to find that egg, reach that egg, and achieve fertilization. So this is a test that we do. We talked about with the workup, we're going to see about the eggs. We're going to do some testing on the egg quantity and quality. We're going to do some testing on the sperm, and then we want to see if the sperm and eggs can get together. And this is another issue that some couples face. We do an HSG test or hysterosalpingogram, and what we're looking to see is that uterine cavity normal? Does it look like there's any complications inside the uterine cavity, scarring, polyps, or fibroids? And are the fallopian tubes open? Can that egg go into the end of the fallopian tube? Can the sperm also reach the fallopian tube and find the egg? And then can that embryo move back inside the uterus safely? And these are just a couple of examples of abnormal HSG tests, but it just goes to show you that if you have a tube that's blocked on one side and a patient ovulates on that side, well, there's a pretty low chance that the egg and the sperm are going to end up meeting because that tube is blocked. If you look on the other side of this same picture, that tube is a little bit big on this side. And what we're concerned about here is that the egg and the sperm might actually meet when we're on this side. On the side, it looks like on your left, it's actually the patient's right, that they can actually meet, but they can get stuck in there and not make it back into the uterus. And that can result in an ectopic pregnancy, where the pregnancy grows inside and can damage the tube and cause complications for a patient. And then the middle here shows that there can be things inside the uterus preventing an embryo from implanting. And all the way on the right, we see uterine anomalies that are different shaped uteruses that make it more difficult to get pregnant, as well as increase a woman's risk for a miscarriage. And this is an ultrasound that we sometimes do with water in it. That's another way of looking at the uterine cavity to see if maybe something is impacting the uterine cavity. And here we see a growth inside the uterine cavity that we would recommend removing before a couple's trying to get pregnant, because there's a good chance that this is inhibiting an embryo from implanting. So different treatment options that we have include just natural cycle monitoring. What that means is that we're just monitoring somebody to see when their egg gets released, and we're kind of instructing them when is a good time to have intercourse to optimize their success rates. For women who don't ovulate, we offer ovulation induction, which are hormones that we use to help get a woman ovulate. And then again, we can instruct them when the best time to have intercourse to conceive is. The next, called controlled ovarian hyperstimulation, is when we give hormone injections. And the goal of these injections is to actually grow more eggs than you normally would. Our goal here is to possibly grow 2, 3, or 4 eggs in a cycle. Our goal is not to obtain twins, although of course that is one of the side effects. But the thought process here is that in patients with unexplained infertility or low egg quantity, the one egg that they're ovulating each month is not doing it. They're coming to us because they're not getting pregnant. And so by increasing the number of eggs, which is really the rate limiting step in these cases where the sperm is normal and the tubes are open, we hope to achieve a pregnancy there. Many of you have maybe heard of something called intrauterine insemination, or IUI. This is the same as artificial insemination, and that's actually the act of putting the sperm inside the uterus. And we do this in a number of different cases, and we often combine it with some of the treatments listed above to improve chances of getting pregnant. And then finally, there's something called IVF, or in vitro fertilization, which many of you have probably heard of. In vitro fertilization, we attempt to grow multiple eggs on the ovaries. However, we're not going to allow multiple eggs to be released because that would be very risky for complications. So we remove those eggs once they achieve a mature state. Once the eggs get removed, we fertilize them in the laboratory, and then we create embryos in the laboratory. When we have the embryos in the laboratory, we can evaluate them. We can evaluate their morphologic appearance, which is how they look, but we can also evaluate them genetically prior to putting them back into somebody's uterus. So this is very helpful for women who experience multiple miscarriages, or for couples who carry genetic disorders, or to investigate the effects of aging, because aging increases our risk for making chromosomally abnormal embryos. And so it allows us in our older female population to be able to test the embryos before putting them inside the uterus. So again, I already showed this slide, but I was just trying to show the difference here. This is tracking a normal menstrual cycle. And then when we want to induce ovulation, we work a lot with the brain's hormones. We actually block certain hormones to the brain to get the brain to then secrete its hormone, which tells the ovary to grow the eggs. And clomiphene citrate and letrozole are two examples of these medications. And we sometimes combine these medications with telling patients when to have intercourse or that artificial insemination. And the injectable medications, like I said, are a little bit stronger in growing additional eggs on the ovaries. And then this is an example of an intrauterine insemination. So this is an office procedure. It takes less than 5 minutes. It should not cause any pain, certainly nothing more than a pap smear would cause. And we actually prepare the sperm specimen ahead of time. That day takes about an hour. And we prep the sperm and we try to concentrate the sperm with the most number of motile sperm in the smallest volume of liquid. And then we put it inside the uterus. And again, that sperm gets deposited in the uterus, but it still has to go through the fallopian tube and meet the egg and achieve fertilization. And then with in vitro, like I said, we're going to use those hormone injections again to grow multiple eggs. And we remove the eggs with an outpatient surgical procedure. So we do put patients to sleep so they don't feel any pain. And we remove them through the vagina. This is an ultrasound. And on the ultrasound is a small needle that gets injected into a patient's ovary. And we drain the fluid that is in the cysts or follicles where the eggs are. And within that fluid, which gets collected, we retrieve the eggs. Once we retrieve the eggs, we fertilize them. There's two different ways of fertilizing eggs. One is to mix it with sperm. This is called standard insemination or conventional insemination. Or we can inject a single sperm into the egg. We often do this injecting of single sperm into the eggs when the sperm quality is poor. And this has been a major advantage of curing male factor infertility because it allows pregnancy to occur in men who don't have that 20 million per milliliter sperm counts. But even with men with just a couple of sperm, we're able to achieve a pregnancy. And then once we fertilize the eggs, they become embryos and we culture them or grow them in our laboratory. And then we have the option, like I discussed, of actually biopsying the embryo, which is where we take a couple of cells out of the embryo so we can check their genetics. And then, of course, we put the embryo back inside the uterus. And that's actually an outpatient procedure, no anesthesia, and again, just takes a couple of minutes. And in this scenario, we're actually putting an embryo inside. So it's not going into the fallopian tube, we hope. It's staying inside the uterus and implanting for a pregnancy. So the next slide, I just thought it was interesting to discuss the percentage of reproductive IVF cycles. Why are people doing IVF in the United States? And this is kind of interesting. One of the most common reasons now is for egg or embryo banking. And egg banking is something that we have started doing to help preserve a woman's fertility. It's used for a lot of different factors, but one is to preserve our fertility for the future because we know with age, it's going to diminish. This is just a little bit about the genetic testing. If anybody has specific questions, we can certainly talk about that, but this has been a major advantage to rule out just the general chromosome abnormalities that plague human reproduction. And then another slide about the egg freezing. This is the best way we have right now to sort of freeze or halt our fertility. It's not a guarantee for a pregnancy in the future. It's important to know that, but it is the best way we have to preserve somebody's eggs at the age they are when they actually undergo this process. And then egg donation is an option for women. If they don't have their own frozen eggs, they can get frozen eggs or fresh eggs from a donor. And this is a very common treatment that we use when a woman's eggs are no longer viable. So I thought Dr. Weiss would maybe want to take it from here and talk about her aspects of fertility treatment and the importance of the emotional support and the psychological and nutritional aspects.
Sure. Thank you, Dr. Greenside, for the overview. I think it's really helpful to see from sort of beginning of trying on your own to the most advanced treatments that we have, how many options there are. And certainly I'm really glad that you did talk about how common infertility experience can be. Gosh, almost 10% of women go through it. Because it is something that's really difficult to go through and can bring a ton of challenges for people when getting pregnant is taking longer than they would have expected. So I'm going to talk a little bit about some of the common themes that people experience when they're going through trying to get pregnant and it's taking longer than they would like. And I'll try to address some of what to do about those things, although it's pretty brief, but certainly anyone that has more questions can put them in the Q&A and we can go into any more depth at the end for whatever topics you're interested in. But as I said, when you're trying to get pregnant and it's taking longer than you wished, it can seem to affect everything. It can strike right at the heart of your life plans. It can affect your relationships. And it seems to even impact confidence level, how you see yourself, and can strike even at the heart of your values and have you question what's really important and what are your priorities. And certainly every person brings their own personality, their own quirks, their own life story to the situation. There are definitely some common themes that I hear people talk about over and over again when they come for help to cope with trying to get pregnant. I think one of the most common, and perhaps some of these things seem really obvious, is people really afraid of the future. When you're disappointed and you're trying to get pregnant, it's not happening as quick as you would like, it can make you really afraid of what to expect in the future. And anxiety can creep up about the unknowns, wondering if you'll ever get pregnant, not knowing if it'll be soon, if it'll be a really long time, or whether it will ever happen. And people often start to wonder, what will life be like if this never happens for me? And again, I'm going to try to address a little bit on how to cope with these things. And certainly thinking far out in the future can make one very anxious. And one of the best strategies for dealing with those fears is to, as much as you can, stay present and focus on one step to the next and not get too far ahead of yourself. And of course, this is much easier said than done, but they're very specific cognitive strategies. If anyone's heard of cognitive behavioral therapy, which focuses on the thoughts that we have, we can sort of catch the thoughts that are making us feel worse, including looking at the future rather than staying in the present. And you can practice and be taught to stay much more in the present, which can be easier to cope with. Another common theme is people feeling really stuck where they are. Many people have described trying to get pregnant as being on a merry-go-round, on a cycle that goes through every month, where they're just spinning their wheels or being on a treadmill, when it seems like other people in their lives get to move on to the next stage. It can, really make you feel like you are not quite an adult yet if people around you are having children and you're not, or just like other things are all on hold while you're waiting to have a baby. Maybe avoiding making career changes, planning vacations, and just feeling that they're stuck doing the same thing over and over again can get really frustrating. Many people talk about how it's even more frustrating when younger siblings get pregnant first and maybe give their parents' first grandchild, younger cousins. And there are many people who see their friends having already second, third babies while they're still, again, stuck trying to have that first baby, which can be really sad. It can be really frustrating. And I think, again, one of the things that can be helpful is when it seems like everyone else is moving on and you're staying still. Dr. Greenside just shared with us, again, the statistics are, there are a lot of people in the same situation. And sometimes, when we're sad or when we're frustrated, we only see what we want and we don't realize the people around us who are perhaps keeping private about their situation, but maybe are going through the same thing. But certainly it can be very frustrating and very sad when you don't get to move on when you're ready. And again, while you're seeing other people move forward and other people having success, it can lead to, a lot of trouble dealing with family and friends. It's definitely not easy when you feel stuck, you feel unlucky, and it seems that other people around you are getting what they want. And it seems like other people around don't even understand what you're going through. Even people who really mean well, people who care about you, can say things that make you feel worse. Some people can be intrusive and ask too many questions when you don't want to talk about it, or you feel like being more private, or the opposite can happen. It can seem like you wish people would ask, and they don't seem like they care because they're not asking how you're doing or what's going on. And sometimes it feels like no one can do anything right, and you don't even know yourself what you want anybody else to do, because it just seems that you're unhappy and you don't know how to deal with the people around you. And I think that, again, there's no simple answer to address all of that, but communication really helps. I think people around you generally do really care and would like to know what you want. And it's helpful if you let them know, telling people, listen, I'm going through this, but I'm being private about it. I'll let you know when I'm ready to talk. Or the opposite, listen, I'd be really glad if you asked me about it. It's something that's hard for me to bring up. Not everyone wants to talk about it with family and friends. It's certainly your own, personal business if you don't want to share with anybody. Sometimes it makes it a little harder because then people don't know to be sensitive to your situation if they don't know. But you have to kind of judge for yourself, who are the characters in your life? Who are your friends and family? Would it be more helpful to have their support and for them to know? Or some people, they know that it wouldn't be more helpful for the people in their lives to know, and then they choose to keep it to themselves, which again, everyone has to know their own situation and judge the people in their lives. Back to, in general, friends and family, social media can be especially painful. Never knowing what you're going to see, who's going to be announcing pregnancies, people posting sonogram pictures or pictures of baby bumps. It can be a constant surprise and constant feeling like attacks or like a gut punch, to go on and see what people are posting. We know from tons of research outside of fertility that the more time people spend on Facebook, the more depressed they are. Again, which way is the causation? We don't know. What we do know is certainly associated with not feeling good. So sometimes I advise people to shut off their notifications. If they're insisting on going on social media, have a set amount of time they're going to do it, and go on when they feel they're up to it. So not just letting things blindside them throughout the day, but maybe deciding that they're going to check social media maybe before their partner or spouse comes home, so they know that once they come home, they're going to have support to talk about whatever they encountered. Or to limit the amount of time they're going to give themselves, a certain number of minutes per day. And if it still is too painful, maybe you need to shut it off for a while, which can be really hard, but taking care of yourself going through this is so important. It is hard enough. And so being careful not to make things harder for yourself. And listen, if it's hard to be around people, it's hard to check social media because it's painful. This can be a very isolating experience. Pulling back from, for participating in life events. Many people do not want to attend baby showers or first birthday parties. And often the most common question I get is, should they push themselves to go? Everyone thinks they should go, or they're told that you should be happy for other people. So should they be happy? And it's certainly not a one size fits all answer. The questions I ask of people when they bring that to me is, first, really starting to weigh the stress of going with the stress of not going. How important is that person to you? What's going to be the consequences of not attending? And thinking out sort of, again, sometimes you're between a rock and a hard place. You don't want to go, but you don't want to not go. And it's really just thinking about how important is that person? How much can you get away with? But also really valuing taking care of yourself. So if you choose to go because it's the path of least resistance, how can you take care of yourself while you're going? Is there someone that's there that will help to sit with? Can you perhaps leave a bit early and avoid watching gifts being open? Having perhaps an escape plan, of someone that can call you and say that they need you either in another room or to go home early. And again, there's no great answer to all of this, but just kind of weighing what's the easiest for you. And I think it's important to acknowledge that you are important too. Just because someone else is pregnant in their party, you have feelings, you're going through something difficult, and figuring out a way to take care of yourself during the process is really important, and you deserve to feel well as well. It's really hard to admit to yourself if you have feelings of jealousy of other people who are pregnant. people often get mad at themselves for having that feeling. I have to say probably, I don't know, it's not a real research, but almost all the patients I see have some degree of jealousy of other people that are pregnant. And if that many people feel it, it's not because they're bad, mean, or not a good friend. It's because it's a situation. If almost everyone feels that way, then obviously it's a situation and not the person. So I think it's okay to acknowledge to some extent to people that are safe and supportive, perhaps your partner or perhaps a support group or a therapist, but being able to have your feelings and feeling that it's okay to have them is an important part of acknowledging that you're not doing anything wrong. That is just, you're just having a hard time. But speaking of relationships, you might also be worried about the impacts of having fertility problems on the relationship with your spouse or your partner. Certainly this can affect couples in all kinds of ways. For some people, it can be a positive where they really bond over the experience and are supportive of each other, can feel sometimes like it's them versus the rest of the world or them versus the universe. But for some people, it can really be a stressor. When you don't feel like yourself, when you're upset, you might be acting in ways that aren't good for the relationship. Or you and your partner might be on different pages about what your next steps should be, which can really be a challenge because then you can feel even more alone. And of course, as Dr. Greenside said, most people don't get pregnant on their first try. And often that first month of trying can feel liberating without birth control. And there's a lot of excitement about going forward in that way. But when it takes longer than you expect, it certainly can have an impact on your sex life as well, which can have an impact on intimacy and the closeness you feel with your partner. So certainly, there's a lot to unpack there. I can give a very brief overview about the potential impacts on your relationships. But I think certainly being able to feel that you're entitled to your feelings, your partner is entitled to their own feelings. You don't have to feel the same way to be supportive of each other where you each are at. And it doesn't have to be threatening if your partner feels a different way. You're different people. You don't marry someone exactly like yourself. Everyone has their own, their own history, their own personality. And sometimes when you go through something stressful, you kind of pull more to the things that are in your own history as opposed to things you developed as a couple. You kind of retreat to the known or go to like old coping strategies. So, being understanding that everyone handles things in their own way, again, while being supportive and asking for what you need can go a long way. I think another big theme that people talk about when they're going through infertility is simply stress. From all different directions. Stress from simply juggling medical appointments and work, stress from financial impacts of trying to have a baby, even people who have insurance coverage. It can be a cat and mouse game with getting the information from insurance companies, getting approvals in time, to start a treatment, feeling like things are being held up when you're ready to go. And even when you get approvals, it can be a cat and mouse game getting them to actually pay. So there certainly can be, a lot of stress from the actual treatment process, as good as our doctors are about, and as good as our office is about helping people through that, it's somewhat inevitable. And I think the kicker is that everyone says you shouldn't be stressed out while you're trying to get pregnant. So here you have all the stress of not getting what you want, going through all this treatment, juggling everything, and feeling worried that the stress of the process is going to backfire and make things even harder. So then you stress about being stressed, and it's like a really bad cycle. A lot of people will even be told by their spouse, by their partner, oh, you have to think positive, don't be stressed, this is bad for everything. And it really, to me, causes an even bigger problem when people believe that they have to think a certain way for it to work. There's really, no magic about you have to think positive for it to work. But certainly what you are saying to yourself can make you feel better or worse. So to me, it's not about eliminating all stress. That's impossible. It's learning what things help you to manage stress. What ways can you take care of yourself day to day? And do those things not because they're going to help you get pregnant. Do those things because you deserve to feel better. And you have to find a way to live with the process and have the stamina and energy to live with it until you get what you came for. So the idea of stress, so you can feel better, so you can live with the process would be my focus, as opposed to managing stress as a means to getting pregnant. Dr. Greenside and the doctors take care of that part, and your job is to take care of yourself. I think another big thing that comes along with infertility is just feeling helpless. Often in life, we all have come to the point where we believe that the harder we work on something, the more likely we are to get our goal, and the quicker we can get our goal. So if you want to go for a promotion, you work harder. If you want to get through school, you study more. If you would like to work on something in your house, you get everything on a list and you work on getting it done. Can you make it quicker to get pregnant by working harder? Doesn't quite fit the same model, and many people cope that way with working harder. But with this, sometimes on one given day, there's not much else you can do. There's a lot of waiting time. There's waiting for a next cycle to start. There's waiting for results to come. And many people can start feeling helpless and don't sit well with that. They feel there's nothing they can do but wait. That again, maybe it's now the doctor's job to get them pregnant and there's nothing that they can do. So what I do when I work with people going through this is help them see that if they broaden their goal, not just that today I want to do something to get pregnant, but today I want to do something to take care of myself. Today I want to do something that will make me healthier so I can have a healthy pregnancy, healthier life. Well, now there's a lot more things we can work on. And so these are the lifestyle behaviors that Dr. Greenside referred to that can not only perhaps help set you up for success with getting pregnant, but that you can really use to feel more proactive in the journey. So perhaps in one day, there's nothing you could do to get pregnant today, but you can think about what's a healthy dinner. You can think about who to reach out to for some social support. You can think about making an appointment for acupuncture or do some meditation and do things to take care of yourself. And it's not so much that those are distractions to keep you busy. They're really good because all of those lifestyle behaviors and those strategies are going to give you the stamina and energy to keep going through treatment until you get your goal. We know from research that the top reason people quit is not because they run out of money. It's not because doctors say there's nothing we can do. People run out of energy and stamina and have trouble living through the process. So finding a way to feel proactive and less helpless, feeling a way to take care of your emotions, and feeling like you can still sort of fit fertility into your life rather than making it your life is sort of the way to cope with it for the longer term. And listen, this is all challenging. Again, me saying this one time is not going to make you be able to do it, just snap of the fingers, but these are sort of ideals to work toward. And there are definitely, ways to do that. Let me see. I mean, I think those are the most common feelings and common reactions that I have people come in talking about and that I hear again and again. I just wanted to give just a brief information about how do you know when to reach out for help. If I'm saying that these are all common feelings, well, does that mean that you should just accept them and that you just live with them and that you don't need to do anything? I think just because they're common does not mean they're pleasant. It doesn't mean they're easy, and it doesn't mean you should just accept them, even if they're common and I guess normal. But you should definitely reach out to a mental health professional if you have sadness or nervousness that just doesn't let up. If it feels like it's there all the time without breaks in between of enjoying things, then it's be the time to reach out and figure out how to live life again. It's definitely important to reach out if you feel you can't enjoy anything, especially things that you used to enjoy. If you're not interested in seeing anybody, if you're not interested in doing anything, well, again, now your whole life is just infertility and you're not living anymore. So it'll be really important to try to figure out how to smile again and how to enjoy some things again while you're still working on reaching your goals. It's important to definitely get an assessment if you're having symptoms like panic attacks, if you have very low mood, if you're having trouble eating, trouble sleeping, trouble concentrating, if having those kind of symptoms or your sadness about trying to have a baby is impacting work, if it's impacting your relationships, again, it's time to reach out. If you're having trouble controlling your irritability, it's time to reach out. And of course, especially if you're having any scary thoughts and feeling that life isn't worthwhile, that's an emergency that you need to let your doctor or call 911 or just reach out for a therapist, at that time. So I hate to end on sort of a negative note like that, but certainly there are a lot of things that you can do to get through this a bit easier, learning better coping skills, learning self-care, getting some support, and just learning specific coping strategies to get through an IVF cycle, get through waiting periods. And there's certainly a lot written about this, and there's some good therapists out there who can help you through it.
Wow, so informative, both of you. Thank you. I do have one question. And also, folks, if you have more questions, keep sending them in. When should you consider embryo banking?
So embryo banking is when you're going to freeze sperm and egg that have already been combined. So embryo banking is often used when a couple knows that they want to have a baby together, no matter what happens over the next couple of years, however many years it is until they use them. So we cannot separate a sperm and an egg. Okay, so once we put it together, we make an embryo. So embryo banking, we do in certain circumstances. People that want to wait to get pregnant for a variety of different reasons. I do it frequently when I have a patient who's been affected with cancer and they need to undergo cancer treatment that's going to render them infertile or potentially infertile. And so a lot of times in that scenario, we'll want to bank some embryos. There are sometimes patients who have certain genetic disorders or medical disorders that they're not going to be able to carry a pregnancy in the future. And those couples might want me to preserve their embryos for the use of somebody else to carry those embryos down the road. And they know that they're not ready for a kid now, but they know that their pregnancy rate is going to be a lot higher if we bank their embryos at a younger age rather than an older age. So that would be another potential reason that we bank embryos. So there's definitely a variety of different reasons, but it's basically putting your embryos in a holding pattern. It's very good. It's very successful, but it's a unique situation.
Great. Thank you. So I think you both answered so many questions. You were both so thorough, and we appreciate you joining us this evening.